is not to get the right answer, which I'm sure all of you actually do have the right answer, but it's to get to the right answer. And so if you have any questions throughout, just let me know. You can put it in the comments, or if I stop talking, you just ask. All right. So the case is a little different from what I gave you. I changed a few things, but it's generally the same. So we have a 45-year-old male who presents to the ER at 1 a.m. with substernal chest pain. And the history that we got initially was from the EMTs. So the EMTs say that the patient was at a party, he was dancing, and he suddenly felt a crushing pain across his chest. He said that it was the worst pain he's ever felt in his life, and it was radiating to his neck. So he felt neck pain as well. The pain has been constant. His friend gave him some medications, which we later find out was Percocet, and the Percocet helped it a little bit. And so upon arrival to the ER, you see him, he's inebriated, so he's drunk. But you look at him and you can tell that he's anxious. And he looks like he's in distress. It's hard to get a history from him, but his girlfriend is there and she's giving a little bit of a history there too. So with that initial history, Dr. Schultz, what do you want to know first? What part of his history of present illness do you want to know about?
I would like to know, I'm personally interested in like a drug history.
Okay.
Since he was at a party, he likely was drinking.
Okay.
But normally you don't get very anxious with drinking, so he might have been doing like some sort of party recreational drugs with it.
Yeah, so his girlfriend tells you that he was seen with an old friend from law school. He was drinking more than he usually does, and there was a few times they went to the bathroom, and as the night progressed, he got really rowdy. He got more active, and he started jumping up on tables and started dancing. That's all the girlfriend really knows. But good. So, anything else that you'd want to know, Dr. Schultz?
Immediately, I would like to know about the type of like crushing pain. Like, is it if like centralized like heart, or if it's like with his while he breathes and stuff as well?
Yeah, good. So what makes it better? What makes it worse in its position? So good. So nothing really seems to make it better. The Percocet did make it a little bit better, but it's really severe, so nothing's really making it worse. And the location, he said, the EMT said he had mentioned it was substernal, so it's like right in the middle of the chest. But when the girlfriend tells you, I believe it was the girlfriend, she says that he was feeling it across his entire chest. But good. So, Dr. Wahid, what else do you want to know?
And asking if the pain radiates.
Okay. So he's saying that, or the EMTs told us that it radiated to the neck. So he was complaining of neck pain as well. Does that mean anything to you? Does that ring any bells or mean anything specific?
Maybe to check for any like jugular distension or like abnormalities.
Okay. And what would we be thinking about if we had jugular distension?
Is that a cardiac issue? I'm not sure.
It can be, yeah. So jugular distension usually is because you're not able to push the fluid that's going to the heart. You can't actually push it forward. So you see it in heart failure. You see it in stuff like cardiac tamponade, where you're having too much fluid between the heart and the sac itself, and because of that, there's too much pressure put on the heart, so you can't actively pump the fluid out, and so it backs up, and you can see a little bit of distension in the neck.
Okay.
Good. So, but yeah, so it radiates to the neck. What if I said it radiated to the back? What would that make you think of?
A pneumo, maybe?
Maybe. What else can cause radiation to the back?
Aortic dissection.
Aortic dissection. Perfect. So,
Okay.
so when the aorta dissects, remember the aorta travels to the back of the body, and so it sits right above your spinal column. And most people will have that tearing type chest pain that radiates to the back. So good. All right. So the girlfriend tells you that while he was up on a table, he fell down on the floor, hit his left side, including his left chest, and he was complaining of chest pain after that. So, so Dr. Faruqi, anything you're concerned about with that? All right, let's go with Dr. Swami. What would you be worried about in that instance?
Can you hear me?
Yeah.
I would probably check for any internal bleeding, like in the head or any head trauma after he fell.
Good. So, so why would you jump to head trauma? What's the thinking there?
Because when his girlfriend said he fell, I'm assuming that he might have hit his head, and if he hit his head, then he could have internal bleeding, probably like a hemorrhage, maybe.
Potentially, yeah. So, if you're thinking more along the lines of him being altered, being maybe being confused, potentially it can be from the alcohol, but you can't. If he had a fall, you always want to think of a brain bleed, because the last thing you want to do is miss one, because the brain is enclosed in a pretty solid structure, and so there's no way for anything inside the cranium to move out. And so if you're filling that volume with fluid, well, that's occupying some of the space that the brain usually fills, and so the brain is going to get compressed, and if it gets compressed too much, it can herniate downwards, and you can cause brain herniation, and if you herniate too much, you can cause arrest of all respiratory function, and the patient can die. So that's always something you want to take a look at and see. You can always do a physical exam and see if there's any head trauma or any like cuts or bruises or anything like that. But if they have a head, if they hit their head, we would typically get a CT or something like that. So the girlfriend said he didn't hit his head. That's a good thought. Dr. Wilson, you said you had mentioned, I forgot what it was. So what do you think? What are you?
I mentioned lung puncture. I was thinking if the person, can you hear me?
Yeah.
Okay, so I was thinking if the person were to fall, there's a possibility that they could have like fallen and hurt their ribs possibly. I know that would be like an extreme fall, but you never know. So I was thinking maybe lung puncture.
Yeah, so if you end up with, so if you have a patient that fell down, and you can get it from the fall at the level of a table. So like if he fell over and hit his side on the edge of a table, that can definitely cause a rib fracture. And so if the rib fractures and goes inside to the lung parenchyma, you can cause something like a pneumothorax, or worse. So what would be something that would be worse than a pneumothorax?
Something worse than a pneumothorax.
Or a type of pneumothorax that would kill you.
Wait, I know what it is. Wait. Would it be? Well, I thought I knew. A type of pneumothorax.
Yeah, so if I said that the trachea started deviating, his blood pressure started to drop, some people in the comments are helping you out.
Is it a tension Wait, no, that's not tension.
Yeah.
Okay, it was tension. Okay, I just saw. Thanks. Yeah.
So
it was like right when you said that.
Yeah, so with a tension pneumothorax, what ends up happening is you create a one-way valve between the chest wall and where the lung is. And so as you breathe in, you're bringing air into the space, but you're not letting it escape. And so with every breath, you're causing more compression of the organs inside. And so you're shifting everything to the right. So that's why you get that tracheal deviation. And so as you're increasing the pressure within the thoracic cavity, that compression is affecting the vessels, and you have less return to the heart. And so if you're not having blood flowing to the heart, you can't push it out anymore. And so that's how people die. So good. So Dr. Annabelle, how would you treat a tension pneumothorax? All right, let's go with Dr. Mukherjee. How would you treat a tension pneumo?
I think you would have to you have to get the air some way out of the thoracic cavity. So probably I forgot what it's called, but it's when you put in the needle and then the air comes
Exactly. Yeah. So you stick a needle in there and you try to get as much air out as you can. So you puncture the chest wall with a needle that it has an ability for the air to escape. And as that air escapes, every time you breathe, you're now allowing a way for the air that's coming in to come out. And so you're not having that compression anymore. So good. So we would be worried about a pneumothorax in that case. So Dr. Mukherjee still. We get more history. Okay, so the girlfriend is saying that he complained of a worsening headache as the night went on. So, what do you think? Thinking about that he fell and everything like that, what are you concerned about? We kind of talked about it a little bit.
A possible concussion, and also if he's drunk, he might be getting over the drunk and I don't know, either one of those two, I would say.
Yeah. So with the first part, you said a concussion, right?
Yes.
Yeah. So if you hit your head, and sometimes you don't even have to hit your head. If you have a whiplash injury where your head goes forward and then comes back really quickly, and your brain kind of smacks right in the front of your cranium, you can have a concussion that way. And he started vomiting at the scene. So his girlfriend tells you that he vomited 3 times and he was nauseous. So that fits with a concussion. And so, again, it's that same thing. If he's having symptoms of a concussion or a head injury, you want to make sure he doesn't have a brain bleed. So what would you get? What image?
I would get a CT then.
Good. Perfect. All right. Good. So, Dr. Trivedi, the medications that he is on are losartan and sildenafil. What's important in those? What would you want to know about?
So I guess starting with sildenafil, that one is for erectile dysfunction. It's also a vasodilator. And then losartan, that's an hypertension drug. And you might want to know the side effects for both of the drugs.
Okay. So you definitely want to know that. Which one is more important to know about?
I think the sildenafil for the erectile dysfunction, since it's a vasodilator.
Okay, and why is that important?
So I think so since he's already on a hypertensive drug, it might be important that he's taking a vasodilator, because I think erectile dysfunction has to do with blood vessels, narrowing of blood vessels. So
yeah, so the way that sildenafil or Viagra, the same medication, the way that it works is by dilating vessels. And so with erectile dysfunction, you're dilating the vessels of the penis because you can't get adequate blood flow to maintain an erection. And so he's relatively young. He's 45. And so if he is having problems maintaining an erection, it's probably because his arteries are stenosed, they're narrowed. And if that's the case, and he has stenosis in one part of the body, a lot of times you're going to have stenosis in other part of the body. So in the brain, that can cause a stroke, or in the heart, causing a heart attack. So that's definitely important to know. The fact that you had mentioned that it's a vasodilator is super important, because this guy has chest pain. So what are we most worried about?
Because he has chest pain, he might be taking other chest pain medications,
or let me rephrase it. So if a patient comes to you, not necessarily this one, and says, I have chest pain, what is the first thing you think about and that you want to rule out?
A heart attack?
A heart attack, right? So you have to rule out a heart attack. What do we typically give patients that have a heart attack?
Usually nitroglycerin.
Exactly. And what does nitroglycerin do?
It's also a vasodilator.
Okay. So now we have 2 vasodilators. Can we give both of them?
No, so I guess it would be important to know like when he took the sildenafil last, because if it interferes with the nitroglycerin, then it might like excessively dilate, which would like decrease his blood pressure and then like also lower his perfusion.
Good. And so a heart attack is because you don't have enough blood flow to the heart. So some portion of the heart is not getting blood. And so if you have less perfusion and now you are causing vasodilation, so even less blood is going to the heart, well, that portion of the heart that was starved for blood initially is not going to get less blood. And that part of the heart will get a little bit of dilation because of the nitroglycerin, but at the same time, if that portion of the vessel was pretty significantly stenotic, your body in general will cause dilation of that portion at baseline. So you get this to a point where you can't dilate that vessel anymore, and so everything else is dilating, and that vessel can't dilate more. So all the blood is being stolen to those other parts of the heart, and not the part that actually needs it. So there is. So you're basically, if you use both of those, you're basically starving that portion of the heart of blood. So that's why we don't want to do it. And like you said, it's going to be important to know when the last time he used the sildenafil was. Good. All right. Good job. So, Dr. Abdul Shafi, we talked a little bit about his alcohol use. What else do you want to know about him as far as his history goes? All right, let's go.
When was the last time the drugs were taken?
Yeah, so what time was the drugs were taken? But what else? So we know about alcohol. Anything else you want to know about?
Anything regarding family history?
Okay, so family history is important. Why is that? So why is that important? When would it be important?
Like, I'm not sure.
It's okay. So we worry about family history when somebody in their family had a history of a heart attack, for instance. But we're more worried about it if they had a heart attack when they were young, because let's say like somebody's father had a heart attack when he was 40. That's pretty young to have a heart attack. So that means that the person, that there might be genetic factors or other reasons why he had that heart attack that can predispose your patient to having a heart attack earlier on. So you're going to want to be on top of it. Same thing with cancer. If somebody has a family history of cancer, that patient is going to be more likely to have it. So good. Anything about the social history that you want to know about?
Could you repeat that?
Anything about the patient's social history that you want to know about? So we know he drinks, and he drinks about 2 to 3 drinks a day after work. First of all, is that a normal amount of drinking, or is it not that much, or is it too much?
No.
It's
too much.
It's generally too much. Yeah. So he drinks a little bit too much. And is he do you think that he used any other drugs?
I don't think he used any other drugs, just drinking.
It's possible that he does. So you always want to ask like the family, like, hey, or the girlfriend in this instance, does he use any other drugs? And so he actually has a history of cocaine and methamphetamine use. So it's going to be important to know that, because those can affect his heart health. So good. All right. Okay, so let's go with Dr. Roman. Axel. Or Roman. Sorry. If I mispronounce your names, I apologize. So his vitals show a blood pressure of 185 over 108, heart rate of 121, respiratory rate of 20, temperature of 98.4, and O2 sat of 97 on room air. Anything stick out to you in those vitals? All right, let's go with Dr. Amy. Anything stick out to you in those vitals?
The high blood pressure and high heart rate.
Okay, so what is the normal heart rate?
Isn't it like regularly like 90 something beats per minute?
So if you're talking about sepsis, then yeah, that's a cutoff. The normal heart rate is between 60 to 100.
Okay.
Okay. And then the blood pressure is typically 120 over 80. So yeah, so his blood pressure is super high and his heart rate's pretty high. Anything, when you see these vitals, anything come to mind?
I think like leaning more towards cardiac.
Yeah, potentially cardiac. But let's say he was tachycardic and he had shortness of breath and his O2 sat was 91% on room air. What would you think?
Would that be pulmonary embolism?
Exactly. So if he had shortness of breath, hypoxia, tachycardia, and tachypnea, you should be thinking pulmonary embolism. Good job. Dr. Orselli, you mentioned aortic dissection. Why?
I was just basing that off of the elevated blood pressure and heart rate.
Okay, so good. Is there any time that you would have different vitals with dissection?
Maybe you'd have like low blood pressure if you had like a rupture.
Exactly. So the way that patients typically will die from an aortic dissection is if you dissect and you rupture. And so when you rupture, you're spilling blood into places where blood's not supposed to be, right? And so with that decrease in blood pressure, or with that decrease in volume in your vessels, you're gonna have a decreased blood pressure. Good job. So we'll stick with you. Anything in his physical exam that you want to know about?
Physical exam. Well, I guess you said that there's pain across the chest, and then
Okay.
it says substernal.
So if we're going to examine the patient, what system would you want to look at?
The like no, never mind.
So we're thinking of a heart case, right? So
Yeah.
So we'd want to typically look at the heart first, right?
Great.
Yeah. So his heart exam shows that he's tachycardic, but there's no murmurs, there's no rubs, there's no gallops. His dorsalis pedis and radial pulses are intact, and his cap refill is less than 2 seconds. So really the big thing is that he's tachycardic. His heart is beating fast. If I said that his dorsalis pedis and radial pulses were abnormal, there was, let's say like the left arm was different from the right arm, what would you be thinking of?
Probably like myocardial infarction.
Not so much. For there to be a difference in the pulse, there has to be a difference in the way that the blood flow is getting to them, right? So
Right.
Is there anything that you mentioned previously that can cause you to have differences in the way blood is flowing?
Oh yeah, the vasodilation. Right.
Mm,
Like if there's something in those vessels that's like occluding blood flow.
maybe, yeah. But you had mentioned one of the reasons why he might have a high blood pressure and a high pulse.
Oh, the aortic dissection.
Yeah, aortic dissection, exactly. So if you have an aortic dissection, if the way that the aorta is laid out is the aorta travels from the heart up and down, and as it goes up and creates that arch, you have 3 branches coming off of it, and so 2 of those branches are going to your left and right arms. And so if you dissect into one of those branches and not into the other, then the other one's going to feel fine, but that one that you dissect to is going to feel different. It's going to feel weaker, and so so you'll have that difference. And so if somebody has chest pain radiating to the back and you have those different pulses, you should think about an aortic dissection. So good job. All right, so let's go with Dr. Fernandez. Any other examination you want to know about?
So as far as any other examination, we already did the heart exam. I think that maybe, I'm not sure, I'm not really sure. I think we have a lot of it covered as far as the physical exam would go if we had like things like that.
So we have the heart.
Oh, sorry, you go ahead.
No, so we have the heart exam. So what are other potential causes of chest pain? So we have the heart. What are some other organs?
We could look into maybe some lung causes.
Lungs. Yeah, exactly. And so his lungs are cleared to auscultation bilaterally. But if I said he was hyperresonant to percussion and had distant lung sounds, what would you be thinking of?
I would probably think that there was something, maybe if he had distant sounds, there was fluid, or possibly, I know someone else mentioned a PE, something that might be kind of like stopping airflow to a certain part of the lungs.
Potentially, but like if we're saying that as we tap on his back, it sounds like resonant. It sounds like there is like hollow. What would that sound like? What would that be?
That would be perhaps like a pneumothorax if we're hearing more hollow sound when we tap the chest wall.
Exactly.
So worry about maybe like even a tension pneumothorax, something like that.
Good. Yeah, exactly. So we would worry about a pneumothorax, but the fact that his lung exam is normal, that's super reassuring. So good job. All right. So
Can I ask a quick question?
Yeah. What's up?
Would you check troponin as a physical exam, or is that something else?
Would I check?
Like the
So
troponin?
yeah, the troponin would be more in the labs.
Okay.
Yeah, but good thought. Since you asked a question, I'm going to ask you a question. Other than those two, so the heart and the lungs, anything else you want to know about for this patient in the physical exam itself? So when you're examining the patient.
Since he fell on his left side, and we're not exactly sure how far he fell, like where exactly, there could be stuff, issues with the GI.
Yeah,
organs.
Yeah, exactly. And I think somebody mentioned earlier on, are we concerned about the spleen? We are.
That was me.
That was you?
Yeah.
Okay. So we are. The spleen sits right below the diaphragm, so that can potentially cause some chest pain, but most likely it'll cause abdominal pain. And the reason is because the spleen is very vascular. There's a lot of blood flowing in and out of the spleen. And so if we damage the spleen and we cause a rupture, you can bleed inside your stomach. And so in that cavity. And so in your abdominal cavity, whenever there's blood, it's very, very irritating. And it'll cause some pretty significant abdominal pain. So yes, you can have some chest pain with it, but a lot of times you'll have more abdominal pain than you would chest pain. So, but that was a really good thought. So he's coming in altered though. He's coming in what looks like drunk, but what I typically do when I see a patient is I get the overall examination, like the overall kind of gestalt of how they look. So do they look sick or do they look okay? If they're talking to you in full sentences, they don't look like they're breathing fast, they don't look like they're uncomfortable, they're probably not super sick enough maybe to be in the hospital, but not sick enough where you're gonna have to like intubate them and do a bunch of stuff right away. But this guy, the way he looked, he looked like he was in some pretty significant distress, and he was diaphoretic. He was sweating like crazy. And then he also had some slurring of the speech. Now, the diaphoresis and the distress kind of tells us that he's sick, but what about the slurring of speech? Can we automatically say that it's probably just the alcohol, or should we do anything else? Dr. Perini.
Maybe he has a concussion.
Maybe he has a concussion. What else would you be worried about? So like slurred speech.
I'm not really sure.
Dr. Wilson, do you want to answer that?
I did. You saw my mic go off. I was thinking maybe damage to the frontal lobe. I know that kind of goes with concussion, but also slurred speech due to possibly the cocaine or just intoxication in general.
In terms of what intoxication?
Like from the cocaine and I guess maybe alcohol if we're assuming that he might be drunk.
Yeah,
but
so
we know.
probably, yeah, more likely the alcohol. But what if I told you that when we did a neuro exam, because that's what we typically do, he has slurred speech when we do a neuro exam. What if I told you that he's moving his right arm a lot, but you don't really see the left arm move? What would you be worried about?
I know this isn't something that we discussed, but it could be possibly an interruption, like at a decusation, possibly, like somewhere neurologically. That was prior neurological damage that could also be, we could like ask, as in regards to history, maybe.
Yeah, that's a good thought. If he had a previous history of some neurologic deficits. But what if the wife says no, that this is all new? The comments are helping you out.
Oh, stroke, yeah, stroke.
Yeah. So if he had a stroke, if he had an acute stroke, so like if you tell him to move his left arm, he's not moving it, but he's moving his right arm, you better try and test to see if he's actually going to keep that up. Because if he doesn't, you have to worry about a stroke. So good. All right. So that's pretty much it with the physical. So, Dr. Nihas, and I hope I pronounced that right.
Close enough.
What was that?
Close enough.
Close enough? Okay, how do you pronounce it?
Niehaus.
Niehaus, okay. Dr. Niehaus, what do you want to get as far as labs?
I would say the first one to check would be the troponin.
Good. Low-hanging fruit, it's pending. What else?
Maybe like a full CBC.
Good. So why would you get a CBC? What would you be worried about?
Maybe clotting factors.
You wouldn't necessarily get that from a CBC, although you will get platelets. Now, if your platelets are low, you can think about like if they have a high risk of bleeding, but they're normal.
Infection?
Infection, yeah. So, or some type of inflammation. So what are you going to check to see if he has an infection or inflammation?
So white blood cells?
Exactly. They were normal.
Okay.
So what else do you want to get? So the
Maybe
hemoglobin was
liver enzymes?
the
In
liver
case
enzyme.
it was damaged when he fell, even though it was opposite sides.
So most likely it won't be because he fell. It would probably be because he's drinking. I actually didn't write down the LFTs. So if I remember right, they were a little elevated, but not significant where we're thinking that he has hepatic failure. But that's a good thought. Good job. Dr. Sophia, any other labs you want to get?
I would probably want to see his potassium levels because those can be an indication of cardiac cell electrical impulses.
Good. So if we have, so what would you be worried about if he has a high potassium or a low potassium?
I'm not completely sure, but probably if he had a high potassium, that's kind of just a guess.
Yeah, it's a bit of a trick question because it's both. If you're too low, you can't adequately conduct those signals, and if you're too high, you're put at risk of having arrhythmias as well. So yeah, really good thought though. His potassium is 3.8, which is within it's within the normal range. The rest of his electrolytes are normal. So his sodium's 142, his chloride's 100, his bicarb's 23. What else would you want to get?
Maybe his BUN and creatine levels.
Okay, and why do we want that? It's his chest that's hurting. It's not his kidneys or his back. Why would we want to know that?
So I guess that's not as important.
No, it's really important, but I'm pushing you a little bit because you had a really good answer. So I'm being a little bit harder on you.
Okay. Maybe because if those levels are high, that could maybe be a sign of his hypertension. I mean, we know he has hypertension, but I'm not really sure if that would rule anything out or
yes.
anything.
So if you had high blood pressure for a long period of time that was uncontrolled, it can affect the kidneys, but it's not going to cause an acute kidney injury. His kidney function is normal, but why is it important? Anybody can answer this. Why is it important that we want to know that how his kidneys are functioning?
Maybe just to see, like, if his kidneys aren't functioning correctly, they're also really important for maintaining his blood volume and blood pressure. So if they're not working the right way, like, and he has a drop in blood pressure, then that could really affect his heart.
Potentially, yeah. So your kidneys are going to want to retain more fluid if your blood pressure drops. Dr. Trivedi, so can you explain what you mean by imaging contrast?
Yeah, so basically, like, if he's getting imaging and, like, he needs to use the dye, like, he might, the imaging will, like, need to see the contrast, and, like, the kidney function would be important because it would determine, like, whether the, like, dye would be able to, like, go through, like, fully, or, like, detect even, like, a clot.
Whoa, kind of. So, taking a step back, this guy has chest pain, and it seems like this might be a heart attack. If this is a heart attack, we usually will have to do an angiogram. And with an angiogram, we have to give contrast because the contrast will light up those vessels and see if there's any narrowing of those vessels. And if there is, we can put a stent in, all that stuff. But so if we do that procedure though, and we give the contrast and the kidneys aren't working well, the contrast can make the kidney function worse, and it can get to the point where they're going to have kidney failure because contrast can be toxic to the kidneys. And so whenever you're thinking about whether or not you can use contrast for a patient, you should always think about the kidney function. If you need any type of imaging, think about the kidney function and see if you can give contrast versus if you can't. There's some things that you can check without giving contrast, and typically we use contrast to look for like cancers or infections. There's other stuff as well, but like stenosis we use contrast for. But it's going to be super important in this case that he has a normal kidney function because it doesn't happen all the time, and that can sometimes delay an angiogram. So does that make sense, everybody?
Yeah, that makes sense. Thanks.
Cool. All right. And then there's one last thing that we would potentially want. Dr. Dennis, any ideas? Let's go with Dr. Sasha. Any ideas of what we would want additionally in his labs? Okay. Dr. Posada?
Maybe a toxin test for drugs if we're
Good.
worried about the drug use.
Yeah, exactly. So he has a history. He has a history of a drug that can cause heart issues. And so, yeah, we definitely want to get a UTOX His tox screen came back positive for cocaine, and it came back positive for alcohol. So he was drinking, he was using cocaine. Good. Now we finally get back his troponin. So Dr. Jane, his troponin is 1.2. Is that normal? Is that low? Is that high?
Can you hear me?
Mm-hmm.
It's a little high, or not a little, actually, it's quite high.
Mm-hmm.
Because the normal troponin levels are 0.04.
Yeah, it's less than 0.04, so good. So his troponin is high. So what does that tell you?
That some of the like enzymes within the heart may have leaked out. So like there could be like something wrong with the heart, so like a heart attack or something, or like an MI.
Good. Yeah, so you're having decreased perfusion to the heart. You're having some type of cardiac injury. So the muscle itself is being degraded to some extent, and you're leaking out these enzymes called the troponin, or leaking out these molecules called troponin. And so, so the troponin being elevated tells us that there is something going on. So we have the troponin. What else are you going to want to get to see if this is something that's very serious?
Like another lab or like a test?
Test.
The EKG.
Yeah. So I gave you EKG-A. Do you know, what do you see on EKG-A?
There's, I think, like the ST depressions.
Okay, good. So where do you see them?
The lead 2.
So 2, yeah. Anywhere else?
I think actually lead 3 and then lead 4 as well.
I see them. So okay, so if you're saying V4, yes, I see them. I think a little bit in V5. The ones where I see it the most, it looks like there's some in 1, 2, and AVF maybe. 3, I don't quite see. But yeah, so you're right. So it's ST depression. So what does he have?
Like because of the depressions?
Yeah. So what do we call what he has?
Like a non-ST, or like a ST, the ST, non-STY.
Yeah. So a non-ST segment elevation MI. Good. So he has an NSTEMI. So good job. So Dr. Dana, can you explain what an NSTEMI is? Let's go with Dr. Swami. Can you explain what an NSTEMI is, and as compared to a STEMI?
I think a non-STEMI is just a heart attack that doesn't have a ST segment elevation. But other than that, I'm not sure what the difference is.
Okay, good. So it gives me an opportunity to teach. All right. So with the non-ST segment elevation, so in general, with heart perfusion itself. So the perfusion of the heart muscle goes from the outside of the heart to the inside. So the vessels travel on the outside of the heart, and it penetrates going inward. So the first portion of the heart that gets blood flow is the outside, and it goes and eventually gets to the inside of the heart. And so if there's any lack of blood flow higher up, it's going to affect the inside of the heart most. And so in this case, since he's tachycardic, his heart looks like it's working harder. There's probably a supply and demand issue where you're not being able to get as much blood flow into that portion of the heart. So the heart muscle is going to have ischemia from the inside to the outside. And so the difference between an NSTEMI and a STEMI is with an NSTEMI, the vessel is not completely occluded. So you have at least a little bit of the vessel available for blood to flow through and eventually get to the heart. But that's generally not enough to perfuse that innermost part of the heart. And so you end up you end up having ischemia in that part, and that gives you the ST segment changes, and it also gives you the troponin being elevated because you have that leakage. Now, if at some point you have complete occlusion of that vessel and nothing is getting past it, now that whole portion of the heart, that entire segment, is at jeopardy because nothing is getting blood, and so you have a full thickness, basically death of the heart, and that causes the ST segments to elevate. And so, so with an ST segment elevation MI, it's basically you're completely occluding versus an NSTEMI. You have a little bit of blood flow still to actually perfuse a little bit more. Does that make sense?
Yeah, that makes sense.
Okay, good. So in this case, he didn't have a STEMI; he had an NSTEMI. So Lily is asking, it doesn't take up the full ventricle, it's not the full thickness. Yeah, exactly. So that's what an NSTEMI is. And then Amy, Dr. Amy, is saying that do all NSTEMIs turn into STEMIs? They can. They don't all have to. It depends on the intervention that we do. I don't know if we don't intervene on an NSTEMI. I think they would typically turn into a STEMI eventually, but I'd have to look that up. I wouldn't say for 100% certainty if that's true or not. Intuitively, it makes sense that it would, but I'd have to look it up just to be 100% sure. That's a good question. Good. All right. So the patient is diagnosed with an NSTEMI, and he started on appropriate therapy. Dr. Kathy Nguyen, what therapy would you want to start on this patient?
I'm not quite sure about this one. I might need some help. Like the comments are saying anticoagulation. Could you explain a little bit?
I was going to ask you to explain. Okay. So with an NSTEMI, like we talked about, the blood vessel is not completely occluded, right? So you have a little bit of space for blood flow to pass through. Now, the biggest worry with an NSTEMI is for it to turn into a STEMI. So if that vessel is completely occluded, you're going to have full thickness cardiac death. Now, how does that happen? Well, if you have a plaque and it ruptures, and you then you form a thrombus, you form a clot on that area, that's going to occlude it completely. Or if you have a clot that is forming there, it's causing a little bit of narrowing, but it's not complete, then the fear is it progressing to completely occlude that vessel. And so anticoagulation is not going to break up that clot that's there already, but it's going to prevent it from propagating and from completely occluding that vessel. And so we use anticoagulation like heparin and do a heparin drip, typically is what I would do, to prevent that clot from getting bigger or to prevent a clot from forming in the first place. And your body, if there's a clot there already, your body will absorb the clot on its own. Does that make sense?
Yeah.
Okay, good. So we started a heparin drip on him, and he received Ativan. Dr. Zia, do you have any idea of why we give Ativan for this patient? Or what is Ativan, first of all?
Hi, can you hear me?
Yeah.
It's a benzodiazepine, right?
Benzodiazepine, yeah.
Benzodiazepine. Usually it's used for anxiety, I believe, and because he's sweating and he's in a lot of distress, maybe that could help.
Okay. But if we're treating a heart attack, why would we necessarily care about his anxiety?
Would it be because if you're anxious, your heart rate goes up?
Yeah, and it's specific to this patient because of the cocaine. Because the cocaine is causing that sympathetic overdrive, it's causing his body to be in that fight or flight state, and it's causing his heart rate to move to beat faster. The benzos are going to help calm all that down, so his heart is not working as hard. And so, so we would typically give a benzo for patients that have what's it called, MI because of cocaine, if they have ongoing issues. And then a benzodiazepine, Ativan or lorazepam is the one that was given here. You can give other ones, and then the ones that people most know about is like Xanax. That's like the prototypical one that people know about because of its abuse. Good.
Sorry, I just had a question on that.
Yeah.
Would that also be included for like alcohol? Like, does that help with the alcohol withdrawal?
Good, yeah. So if we're thinking about alcohol withdrawal, it can help with that because it's in that same signaling pathway in the brain that it's a GABA receptor. I forget the exact one, but basically when you take alcohol chronically, and you have an upregulation of those receptors. And so as you withdraw, you're withdrawing from a lot more receptors than you would normally. And so you're at high risk of having alcohol withdrawals and progressing to delirium tremens and or the DTs. And so the DTs it's a kind of a syndrome that you get from the withdrawal that can be very dangerous and can lead to a seizure. And if it's not treated adequately, you can die. And so the way you treat it is through benzos. Theoretically, you can give alcohol to help with the withdrawal, but that's probably defeating the purpose. But you can give benzos, and patients will typically taper off those benzos and hopefully not drink anymore. But who knows? But yeah, good question. Especially because that alcohol withdrawal can cause pretty significant high blood pressure and tachycardia. So good.
I have a question.
Yeah.
Do hospitals give patients alcohol? If say like this patient came in with he drinks alcohol a lot and he has NSTEMI, so he's probably gonna stay at the hospital for a while.
Mm-hmm.
Won't they just try and get him off of the alcohol usage, or would they provide some for him?
So I think in the past they used to wean people off they used to give alcohol for delirium tremens. I would double check that and to be 100% sure, but we don't typically give alcohol in the hospital. The way we treat the withdrawal is with the benzodiazepines. And so we would have to treat that withdrawal because if we don't, it can be very dangerous. So yeah, we would treat it just with benzos, not with alcohol. Yeah, I hope that answers your question.
Yeah, I did. Thank you.
Okay, so no nitroglycerin was given to this patient because he had sildenafil earlier that day. And so we admit the patient to telemetry and we go back to the call room to try to get some sleep for the rest of the night. So telemetry is basically a portion of the hospital that has patients on continuous cardiac monitoring. It's not really anything, you usually will have an increased nurse to patient ratio, but the most important part is the cardiac monitoring. So at around, okay, let's go with Dr. Babar. At around 6 o'clock, you're paged because the patient is complaining of more chest pain. You go in, you evaluate him. He's breathing super fast. He looks distressed, and he's clutching his chest, saying he thinks he's going to die. What do you want to do next?
Probably put in some sort of a stent, because I think he might have gone more into an MI. So we should probably open up the artery or whatever is blocked. Okay, good. So, but what if he's just complaining of costochondritis and we just stented him? Because the stent has risks, so you want to be sure you're doing the right thing. So how are we sure we're doing the right thing? Probably look at the EKG. Good. We get another EKG because that's the fastest thing you can probably do. If you wanted to get a troponin, you can, but that's going to take a while. So you get the EKG. So EKG B is the one that I gave you. What do you see on that EKG? Sorry. It's very irregular. I don't know exactly how to interpret it, but it's very like... It looks different. It looks off, right? Okay. Yes. So as far as the rhythm, like if you say regularity with EKGs, you're usually talking about the rhythm. The rhythm's actually normal. So there's a beat regularly. But the ST depressions now look like what? Elevated? Elevated, good. So what did ST elevations tell us? I'm not sure. Maybe that the artery has further occluded?
Yeah, and it's completely occluded, right? So you have a STEMI, right? So now you have a STEMI. So you have that full complete occlusion and that heart is at risk. So what do you need to do?
Now we put in the stent?
Now you put in the stent. Good.
Okay.
If you were to check his troponin, what do you expect it to be? His initial troponin was 1.2.
Probably higher then?
Good. So when we first checked it, it was 1.2 and then it went to 1.1. So we knew we were kind of dealing with an NSTEMI. It wasn't evolving to a STEMI at that point. But when we rechecked it, because when we're called for chest pain, we typically say EKG, chest X-ray, and troponin, just straight off the bat. And so we got the troponin, it was 1.8. So it started to increase again. When we repeated it, it was 5.8. So he was having an ongoing heart attack. Yeah, exactly. So, good. So the coronary angio showed occlusion of the right coronary artery, and this was successfully stented, and the patient recovered. Good. So, Dr. Elizabeth, if we did the angio and there was no stenosis, there was no occlusion, what would you be thinking of? Let's go with Dr. Ramirez. What would you be thinking of if there was no occlusion of the coronary arteries when you did the angio?
I would try to look at the vessels if they were narrow.
So the vessels don't look narrowed at all. They look clean, pristine. There's nothing wrong with them. This is a hard question.
I would try to run other tests, I guess.
You try to what? I'm sorry?
Run other tests.
Okay. He has a reason why. So he has a reason why he would have basically a heart attack, but his vessels look good. And I don't know if this was in any of your readings, so it's okay if you don't know it.
Yeah, it's difficult.
It's okay. Dr. Fernandez, why?
Because of the cocaine, it's a stimulant. I think it could cause the vasospasm because it's it's a stimulant drug. It could just cause persistent contraction of the blood vessels. I think I'm not positive, but I think it has to do with the cocaine and then it's spasm.
Yeah, good. Is there any condition that you know of that can cause vasospasm of the coronary arteries? That is not cocaine.
Perhaps he already has high blood pressure, so I don't know. I'm not quite sure.
Okay, it's a hard question. So there's something called Prinzmetal angina, where you have, it typically happens to women, but you have the coronary arteries spasm, and they get clenched down and basically completely occlude the blood flow going forward. And so with the Prinzmetal angina, it's usually transient. So it'll clamp down, you'll feel that chest pain, and then it'll go away as it releases. You're right. With cocaine, you can have it clamp down, and sometimes it won't relieve, and so you can have a full-on heart attack because of that. And so cocaine, there's 3 ways that cocaine can cause a heart attack. These are the proposed mechanisms. So one is what we talked about right now, so vasospasm. You have spasm of that vessel, it clamps down, there's no blood going forward, and so you can have a STEMI-like syndrome. 2 is if you are overworking the heart, because which is probably what happened to him initially, where he had he was tachycardic, he had that sympathetic response where his sympathetic nervous system was causing that fight or flight response. His heart was beating fast, and everything was clamping down. And so you have less blood flow going to that portion of the heart that because you're having your heart is beating so fast. And so because the heart is beating so fast, you're increasing the demand of the heart, but not necessarily increasing the supply of blood to the heart. And so that can cause something like an NSTEMI or even like an unstable type angina syndrome. And so for him, he probably had that initially. The third way it can cause a heart attack is if you it increases the propensity of platelets to aggregate. So basically, you're having an easier time clotting. And so if you have any exposed plaque in that area or narrowing, you're going to have an easier time clotting there. And so the cocaine will facilitate that, and you can have a clot in that area. So that's probably why he went from having an NSTEMI to a STEMI, because he probably clotted in that area. So he probably fit 2 of those syndromes. I don't think he had vasospasm. But good. Any questions about that? All right. So Dr. Yash Patel, let's say he goes home, he does well, and his girlfriend finds him 2 days later dead on the floor. What is one thing that could have happened to him while he was at his home? Like the reason why he might have died. Good thought, Dr. Ramirez. OD is a really good thought, but no. Something that has to do with the heart. Dr. Rosselli said heart failure, potentially, but it wouldn't cause sudden cardiac death like that. Syncope wouldn't necessarily cause cardiac death like that either. Dr. Swami is saying heart attack, so potentially as well, but if it's a massive one, maybe. But there's something else that's more common post myocardial infarction. And anybody can answer if you know why. Dr. Niehaus, sorry if I said it wrong again, saying a new clot, which potentially, yeah, but it's not going to be that sudden cardiac death that we're talking about. So somebody in the YouTube comments said VFib. So yes. So VFib is one of the more common ways people have sudden cardiac death after a heart attack. So ventricular fibrillation is basically when the ventricles, the lower part of the heart that pumps the blood out to the rest of the body, they're not pumping synchronously. So you're not getting that good squeeze to get all that blood flow out. And so what it does is kind of like this fibrillation, which is kind of like this shaking type motion. It doesn't get a good squeeze in. So you basically shut down all blood forward flow out. And so if somebody has VFib and they don't have a pulse, you're starting compressions, you're doing CPR on them. And so you can imagine if this happens to somebody when they're home by themselves, they can potentially die. And so after an MI, because you've changed the architecture of the heart muscle itself, you can have changes in the way that the signals are conducted throughout the heart, and that can cause arrhythmias like ventricular fibrillation. Other things it can cause, like as far as arrhythmias go, it can cause heart block. It can cause, if you have like a heart failure, you can also get like atrial fibrillation. There's a lot of things that can happen, but the one that would kill you is ventricular fibrillation. Dr. Amy is saying, is there any way to prevent VFib? And there is. You can, if you show that you have VFib in the hospital, we can put a defibrillator on you, and it's like an automatic defibrillator to prevent, so that if you do go into VFib, it'll shock you back into rhythm. There's a guy on TikTok, I forget his name. I believe he's an ophthalmologist, and he posted videos about his recent hospitalization that you guys should go look at, because he talks about this and he shows his experience, and he's really funny. So I'll post his name in the classroom so you can go check it out. It's really, really cool. Kind of like Iron Man, I think. Yeah. So I have a question after we finish the case. Okay, so I'm actually done. So if you want to ask that question now, you can.
Okay, regarding our notes, could you hear me?
Yeah.
Regarding our notes, do you want us to put it in columns, like the diagnosis in order from most likely to least likely, as what you stated in your videos? or could we do it our own way? Because we just stated what we think at first about the case, the symptoms, etc., and towards the end we summed it up, like our final resort.
So that's okay. It's really going to be up to you to put it however you want. What I care about is just that you have something there. I just gave you that format because it's going to be a little bit easier. And so, like, for people that didn't have a format already or they were confused, they actually had a format to go by. But really, it's going to be up to you, whatever you want to do.
Okay, thank you.
Okay.
I also have a question really fast about the differential diagnosis. Is that just like us going through what we think it would be?
Yeah. So for instance, for this case, we kind of talked about some of the differentials. So initially with the fall, it might have been a pneumothorax, he's tachycardic, so maybe a pulmonary embolism, but most likely an MI because he had elevated troponin and all that stuff. You didn't have all that information there, so whatever you have, that's good enough. You don't have to go back and do it unless you really want to. So yeah, if you want to go back and watch the video and get all that information, that's okay, but you don't have to do it. So whatever you have, go ahead and just submit that. It's not for a grade, it's more for participation. And then if you had questions about your differential or wanted to see if you were on track, you can let me know, we can review it.
I also had a question.
Yeah, what's up?
So for people who have a VFib, how long did they have
before they die?
Just like, yeah, is it sudden or about a short amount of time?
So it's not sudden like a massive pulmonary embolism where you're just going to drop dead right then and there. It'll take, I don't know the exact time, but it will be basically the same amount of time for you to fully die after your heart stops. So I have to look up that timing, but it wouldn't be sudden like a massive pulmonary embolism. Okay. Axel's asking if we handwrite our notes, can we turn it in as pictures? Yeah, that's fine. As long as you submit something, that's okay. Is there any way to detect VFib beforehand when he was at the hospital? Yeah, so that's why he was placed on telemetry. So with telemetry, you are constantly monitoring his heart signals to see if he has something like ventricular fibrillation. So that's why we put patients on telemetry, also to see if there's like a heart block or something, but mostly because of VFib. So that's how you would detect it. Yeah, so VFib, so the way that the heart signals propagate, usually it starts from the top of the heart, transmits down, so the AV node, the the SA node, is where the heartbeat starts. It causes contraction of the atria, and it relays down to the AV node, the atrioventricular node, which is between the atria, the top of the heart, and the ventricles, the bottom of the heart. And then from there, it collects there and then propagates down to the ventricles. So all of these signals are causing rhythmic contractions of the heart. So if you have a good conduction system going from the top of the heart to the bottom, you're pumping blood from the top to the bottom, and then from the bottom up to push the blood out to the rest of the body. With ventricular fibrillation, you're not getting the signals from the top as the signal to contract at the bottom. What ends up happening is you have signals starting from the muscle itself, from the ventricles themselves, the bottom of the heart, and so what ends up happening is those signals are originating from erratic points, and so you're not having that synchronous squeeze. So one signal starting here, the other one's here. So this is squeezing a little bit, and then the one over here squeezing a little bit. And so it's kind of squeezing not synchronously, and so you can't push that blood forward. And so instead of doing that good squeeze, you're kind of doing this like shake that's not actually pushing any blood forward. Does that make sense? Dr. Orselli's asking, is it Purkinje fibers or literally the muscle? If I remember right, I think it's literally from the muscle itself, but I'd have to double check that. Right. Would VFib happen pretty close time-wise to an MI, or is it like a risk for the rest of the life? If I remember right, most of the time it's happening pretty close after an MI. I do think you're at an increased risk for the rest of your life, but I'd have to double check that to make sure. If you remind me, I'll take a look at and see. Do we have to turn in our notes at exactly 1:59? You don't. It's going to be up to you. As long as you turn it in before time, that's okay. Okay. So I forgot to mention for the other classes too. So your quizzes, I'm actually going to open tomorrow because I want you guys to see tomorrow's sessions also, because it's going to be a different case. And that session is going to be pertinent to your post-quiz also. So I want you to learn as much as you can before you take the post-quiz. Yeah. Any other questions before we sign out? No? All right. So I hope you enjoyed it. I hope you learned. And let me know if you have any feedback or if there's anything else you guys want to do.
Wait, I have a last question.
Yeah, what's up?
So people going tomorrow are going over case 1?
So they're going to be going over case 1, yes.
Okay.
Yeah. So it'll be worthwhile if you guys reviewed it with your group to see what case 1 looks like too.
Okay.
Okay. All right, guys. Thank you. I had fun. Hope
Thank
you.
you.
Bye.
Thank you. Bye.
Thank you.